STD testing, we have herpes simplex, which is the quote unquote silent epidemic, 45 million or more cases in the US and greater than 1 million newly diagnosed every year. Almost a quarter of Americans, if not more, have HSV-2 antibodies by the age of 30. So 1 in 4 people. Herpes simplex virus can be broken up into HSV-1 and 2. HSV-1 is mainly orolabial lesions, but there is also an increasing cause of genital herpes. HSV-2 is almost entirely genital lesions. 95% of recurring genital lesions are HSV-2. And there can be a primary infection the first time, a recurrent infection, reoccurrence, or even latency, where the person has the virus, but it's not becoming an active lesion. There is horizontal or vertical transmission. Horizontal transmission is intimate sexual contact, typically oral or genital. There's very rare aerosol and fomite transmission, so that's very unlikely. Vertical transmission is through a maternal infant, and can be via an infected cervicovaginal secretion, blood, or amniotic fluid at birth. And autoinoculation is from one site to the other. Primary herpes, the classic symptoms you might see systemic fever, myalgia, or malaise. There could be a complication of meningitis, encephalitis, or hepatitis, but that's rare. Typically, you'll see a local cluster of small painful blisters. They then ulcerate and crust, and they're located outside of the mucous membranes. There can be itching, dysuria, vaginal discharge, and even swollen lymph nodes, as well as sometimes bleeding from cervicitis if the cervix is inflamed. To actually be able to take a swab, you need to unroof the lesion. You can do this with a scalpel or a needle tip because you need to collect exudate, and then you place the swab in a viral transport medium. PCR is available for HSV types 1 and 2 for blood, vesicular fluid, CSF, tissue amniotic fluid, and more, and it's 95% sensitive, and it's more rapid results than culture. A culture can, though, distinguish between type 1 and 2. It's 90% sensitive in an initial outbreak, and then after that, its sensitivity decreases, and it's really not useful in lesions that are greater than 5 days old. In our AMAB individuals, the culture can be taken from the anterior urethra or even a genital skin lesion. Our AFAB individuals, you could do an endocervical canal that could be cultured, but the goal is to try to find an active lesion and get a sample from that. And a pregnant female, you would culture the cervix weekly, 4 to 6 weeks before delivery, but this isn't commonly done anymore given the prevalence in the population. We would really only do that if we had active lesions. HSV serology, HSV-1, 90% of adults are positive for this. Almost every adult carries HSV-1. That's caused typically oral lesions. And HSV-2, 30% of adults are positive. Um, when would you do serology? You'd want to confirm potentially HSV where the history is questionable, or if you had recurrent lesions but a negative culture. Um, Disadvantages are the antibodies will form within weeks of a primary infection, and it can't really distinguish an acute infection from a previous infection. So, who would we serologically test then for HSV? If there was suspicious symptoms or a history suggesting some atypical or undiagnosed herpes, if they do not believe the clinical diagnosis, if anyone's requesting an STD test, you can add that in. If a partner had genital herpes, they wanted to co-test, or if a pregnant woman had unrecognizable genital HSV-2. Moving into our next STI, chlamydia is the most common STI in the US. There's 4 million per year in the US and 50 million worldwide. The most infected women are asymptomatic, and that's why screening is key, and it can be associated with gonorrhea. Chlamydia are bacterial obligate intracellular organisms, so they cannot be cultured on artificial media because they need to live inside of a cell to survive. We use polymerase chain reaction DNA probes or NAAT, which is preferred, and the same swab can be sent for gonorrhea DNA testing. The swab source is pretty versatile: endocervical, urethral, vaginal, pharyngeal, or rectal. Dirty urine, no cleaning prior, can also be tested as well, which the first morning void is preferred. And if we're looking at sensitivity, pretty sensitive and specific overall. Chlamydia culture indication is required for really cases that are undiagnosed or not clear. The sensitivity is not great, but the specificity is 100%. And you could also do this for an everted inner lib swab for chlamydia PCR, and this would be in neonates, so that have received chlamydia via vertical transmission. So the chlamydia DNA probe collection for AFAB individuals, we use one swab to remove cervical mucus. We insert a second swab into the endocervical canal, rotate for 30 seconds, withdraw and place in a gem probe transport kit. And for our AMAB individuals, we try to avoid urination for an hour prior to collection. Insert two swabs into 2 to 4 centimeters into the urethra, rotate to dislodge cells, and then withdraw and place in a gem probe transport kit. Now again, it's much more common to do a urine sample for our AMABs and a vaginal sample for our AFAB individuals. Gonorrhea can be indicated in patients who have vaginal discharge, pelvic pain, urethritis, or penile discharge, proctitis, even pharyngitis, and anyone who's high risk for STIs or who asks for STI testing. Gram stain can help in aid in diagnostics, especially in male individuals or AMAB individuals, as you'd be looking for gram-negative diplococci inside of a white blood cell. There are culture tests and non-culture tests. The non-culture tests are varied. We have amplified tests, our NAATs, like polymerase chain reaction, transcription-mediated amplification, strand displacement amplification, so lots of options. There are also non-amplified tests like DNA probes and gram stains. This is diagnostic in our AMAB individuals, but not in our AFAB individuals, based off of location. Our nucleic acid amplification tests, our NAAT tests, are a reliable alternative to culture, and it's actually preferred testing for screening. Our samples locations can be urethra or urine or cervical swab is preferred, although you can do vaginal. Rapid, it's pretty quick in 30 minutes, and it's relatively sensitive and specific. You can consider a gram stain, either urethral or cervical smear. There'll be lots of white blood cells, and you're looking for gram-negative biscuit-shaped diplococci. But you can have a false positive gram stain for saprophytic necessariae. You could do a gonorrhea culture and sensitivity, and the culture medium of choice is chocolate agar or Martin Lewis agar. And for disseminated gonococcus testing, you could consider blood, throat cultures, or synovial fluid. Now, in pregnancy, a test for gonorrhea should be performed at the first prenatal visit for women at risk or for those living in an area where the prevalence is elevated. And then you repeat the test during the third trimester for those at continued risk. Other populations can be screened based on local disease prevalence and patients' personal risk behaviors. Now, syphilis, the pathogen is Treponema pallidum. It cannot be cultivated in vitro. And so syphilis screening we consider annually for people who we have like that increased sexual risk factors or increased risk factors for STIs. Syphilis screening, which you could consider to do really for any of these individuals, but specifically syphilis screening, you'd want to look at any person who is requesting syphilis screening or any person who is potentially lives in an epidemic or endemic area. It's important to consider screening for syphilis because you may not notice a painless chancre or painless ulcer. And the test, the venereal disease research lab test, the VDRL, or the RPR, the rapid plasma reagent test, will be positive within 3 weeks of developing that primary chancre. You would also want to co-test with HIV because any patient who's positive for syphilis, there could be an increased risk that they are also HIV positive, as HIV co-infection with syphilis is common. And patients who are HIV positive, they're at a higher risk of developing tertiary syphilis or neurosyphilis. If there's a negative test with a lesion present or any other strong clinical indicators, you'd want to consider, again, syphilis screening and repeat screening within 2 to 3 weeks. So what is the screening test? Well, there's non-treponemal screening tests like RPR, rapid plasma reagent, and VDRL, venereal disease research laboratories. And both of these become positive around 2 weeks after a patient is infected with treponema. They would then return to normal after an adequate treatment. Tests are positive in almost every primary and secondary case. Now, confirmatory tests are not the VDRL or the RPR. Those are screeners. So a diagnosis has to be confirmed with a specific treponemal antibody test. And that could be FTA antibodies like fluorescent treponemal antibody absorption or MHATP, which is microhemagglutinin of Treponema pallidum. And they're more accurate than screening tests, but they take longer to become positive, around 4 to 6 weeks after infection. So if our screening is positive, but FTA antibody is negative, you want to seek other diseases that could cause a false positive screen and or retest. Now, these are some things that can cause a false positive VDRL or RPR. Of note, some autoimmune conditions can. Mycoplasma pneumonia, like walking pneumonia or malaria, can. Hepatitis could. Other acute viral or bacterial infections can, or even hypersensitivity reactions or recent vaccines. So there are a lot of things that can lead to a false positive. So, when we're thinking about syphilis testing, we want to consider with VDRL or RPR, after treatment, these would revert to negative or they'll decrease to a very low titer. If there was a significant elevation in either of these tests, that would indicate a repeat infection or a reinfection. But our MHA or FTA will remain positive for the lifetime of patients, so it can be challenging for confirmation. Now, if we did ever see patients, and you probably will in your clinical practice, who present to you after a sexual assault or a rape evaluation, there are specific rape kits, and there are people who actually are trained to collect samples and swabs and material after those events take place. So I would encourage you to encourage your patient to seek care there to make sure the patient can get justice. But it is important to note that after a sexual assault, we would want to do cultures for gonorrhea, chlamydia from the sites of penetration. We'd want to get a wet mount and culture for trichomonas and test patient for HIV, hepatitis, and syphilis. That would be our baseline screens for a patient who has experienced or had a sexual assault or rape occurred.